Which disease cause hyperpigmentation? The first is the Graves' disease. It's a Graves' disease. Any disease which has steroid excess. Steroid excess. So, what are the diseases with steroid excess? It can be Cushing's. It can be Cushing's. Or it can be the exogenous steroid. It can be Cushing's. It can be exogenous steroids. Another important disease is the scleroderma. क्या स्टेरॉइड एक्सेस दो टाइप का ना, कुशिंग होता है, और अगर आपने बाहर से स्टेरॉइड ले रहा फिर भी स्टेरॉइड एक्सेस तो हुआ, तो स्टेरॉइड एक्सेस कैन लीड टू हाइपरपिगमेंटेशन. इन स्क्लेरोडर्मा to be the salt and pepper pigmentation. You will see salt and pepper pigmentation. Salt and pepper pigmentation. Important disease, Peutz-Jeghers syndrome. कल हमने बात की थी Peutz-Jeghers syndrome की. Yes, mucosal staining along with what you will see, intestinal polyps. And this child is at risk of developing skin cancer. These three important points you should know. Then Addison's disease. What is Addison's disease? Aldosterone deficiency. What is opposite of Addison's disease? Conn's syndrome. So Addison's is a hypo, Conn is a hyperpigmentation, hyperaldosteronism. So Addison's disease. What is Addison crisis? Suppose the patient was on steroid. Suppose I was prescribing some patient 6 mg of dexamethasone, but suddenly he stopped taking this medicine. So when he was taking this medicine, his adrenal gland went under the atrophy because patient is taking steroid from the outside. So what will happen if today he forgot to take medicine? What will happen? Now adrenal gland is atrophied. There is no hormone secretion, no aldosterone, no cortisol, no mineral cortisol, no sex hormone. So what will happen? Because of the deficiency of all these hormones, patient will go into the shock. So very commonly this concept is asked: what is Addisonian crisis? What is Addison's disease? What is Conn's? And what is Cushing's? The difference you should know. How to differentiate this disease? Addison's disease. If you see the skin of the renal failure patient, it is also called hyperpigmentation. No, Addison's disease एक डिजीज है ऑटोइम्यून, है ना. इंडिया में टीबी करता है. एडिसन्स डिजीज इंडिया में टीबी करता है. मोस्ट कॉमन कॉज इज टीबी. ये याद रखना. वर्ल्ड में क्या करता है? ऑटो इम्यूनिटी एड्रेनल को खत्म कर देती है, बट इंडिया में टीबी है. सो रेनल फेलियर भी एक हाइपरपिगमेंटेशन करता है. एक्सेसिव आयरन डिपोजिशन. Which disease is called excessive iron deposition? First is a hemochromatosis. So what is the treatment of hemochromatosis? The first line treatment is female में hemochromatosis क्यों नहीं होता? Because menses में blood already निकल जाता है. It is a natural treatment for a girl. So that is why you will not see up to the age of 50 until menopause what you will see that female is not suffering from the hemochromatosis. So what is the actual treatment? Venous section, phlebotomy. And if iron deposition is there, what is the iron chelating agent? Deferoxamine. So if phlebotomy can cause hemochromatosis, what can cause artificial hemochromatosis? Multiple blood transfusion, right? So in which disease patients require multiple blood transfusion? Beta thalassemia major, that is the main disease. So in beta, when you on a beta thalassemia major, you will have a multiple fusion. We will have a multiple blood transfusion. And because of this multiple blood transfusion, what will happen? This excess iron will get deposited. So, because एक ब्लड की जो थैली होती है ना 250 ml की, उसमें 200 ml ऑफ आयरन होता है, इज वेरी हाई. तो ये हाँ नहीं 450 एक यूनिट जो होता है उसमें 250 to 200 जितना आयरन होता है. तो उसमें खाली आयरन नहीं होती क्योंकि डायरेक्ट ब्लड है. तो व्हाट विल हैपन, और हम डायरेक्टली वेन में देते हैं तो every iron will deposit on the organ. Okay, so multiple blood transfusion can lead to iron deposits. So this is artificial hemochromatosis. In the pregnancy, because of excess hormone, because of the increased steroid during the pregnancy, patient will develop cloasma. So if we are talking about the pregnancy, what other medicine can cause hyperpigmentation? Pregnancy is a stage of hyperprogesterone, right? Progesterone is too much high. Estrogen is also too much high, but progesterone is much higher. So if patient is taking oral contraceptive pills, she can have a hyperpigmentation. What is this condition? It is known as a melasma. So this melasma and cloasma, the disease is the same, but in pregnancy just the name is given, which is different. It is cloasma, which is also known as a mask of pregnancy. Which medicine can cause hyperpigmentation? So one we already discussed that oral contraceptive pills can cause hyperpigmentation. Clofazimine. So in which disease we use clofazimine? We use clofazimine in the leprosy, right? In a leprosy we use clofazimine. Chalo, minocycline भी grayish pigmentation करता है skin पे. So in which disease we can use minocycline? Minocycline can be used in a, it is a drug of choice. It is a drug of choice of the fish tank granuloma. Okay. So try to memorize these notes here only because now you have only 50 days. Okay. So try to speak up, try to revise. Okay. Minocycline is a drug of choice for the fish tank granuloma. It can be used in the acne also. Okay. And you know what is the positive agent of fish tank granuloma? Positive agent of fish tank granuloma. It is a Mycobacterium marinum. So how you will remember fish tank means it is an aquarium, right? So it is a atypical Mycobacterium, which is a Mycobacterium marine. Marine means sea creature, right? So remember like this, Mycobacterium marinum will cause fish tank granuloma. So in your exam, if they want to give you a clinical question, what they will give? They will give a patient with a profession who is working with the aquarium, and during his work he got some scratch and then he developed this rash. Okay, so this is a fish tank granuloma, drug of choice minocycline. Clofazimine is a drug of choice in the leprosy. Apart from this, you all know amiodarone drug, right? So what is the use of amiodarone? So it is mainly used in atrial fibrillation and other arrhythmia. Atrial arrhythmia or ventricular arrhythmia, it is a drug of choice, right? It is a drug of choice. Amiodarone is very important drug. Multiple times, many side effects has thyroiditis, hepatitis, right? Skin deposition. So all are important. Atrial fibrillation is a main, but any arrhythmia is commonly use amiodarone. But if you may commonly use it. After amiodarone, you all know chloroquine. These are the medicine causes the hyperpigmentation. These are the medicine cause the hyperpigmentation. हाइपरपिगमेंटेशन क्या उसमें क्या होगा डिफॉर्मेशन में आपके सैफरन कलर के बॉडी फ्लूइड्स हो जाएंगे, है ना? यूरिन में, स्वेट में सैफरन कलर, मतलब पसीना पोंछ रहे हो तो थोड़ा सा सैफरन कलर आ रहा है. So that side effect, not a significant. Hyperpigmentation is a bluish grayish color. Okay, I'm not. There are many medicine cause hyperpigmentation, but these are the main medicine which cause blue or grayish discoloration. You will think that my skin is darkening. Okay. So after this, I will be talking about this image. See this image. This image-based question was asked, what is this disease? This patient was on a oral contraceptive pills. So what is this? This is a melasma. So if I change that, if I say that this patient is pregnant and develop this darkness, here it is a cloasma. So melasma or cloasma is the same thing. Melasma or the cloasma. So what happens due to sun exposure? When this patient has a sun exposure, plus there are trigger factors, which is a oral contraceptive pill, or either the patient is a pregnant. So this is known as a melasma. Another name is also, it is known as a mask of pregnancy. It is a mask of pregnancy. It is a mask of pregnancy. This melasma can be of two types. One is a epidermal. It can be epidermal, means there is increased pigment, but pigment is only in the epidermis. Pigment is in the epidermis. So because the pigment is only in the epidermis, it has a better prognosis. So the reason is, in this disease, patient has a hyperfunctioning melanocyte. In this hyperfunctioning melanocyte, if they are staining only epidermis, if they are staining mainly the epidermis, it is the epidermal melasma. Second type is a dermal melasma. Second type is a dermal melasma. It has a deep pigmentation because melanocyte is sending melanosome to all directions. epidermis and dermis. So deep pigment, and it has a poor prognosis. It has a poor prognosis. It has a poor prognosis. If they ask what is the pathology in this disease, hyperfunctional melanocyte. Hyperfunctional melanocyte. How to treat this condition? So the treatment after the pregnancy, it will resolve. After the pregnancy, it will resolve. So you will tell your patient that don't worry, after pregnancy, this lesion will get lighter, and during the pregnancy, what you can advise, mainly to avoid sun exposure, because sun will stimulate, right? Sunlight will stimulate melanism. So avoid sun exposure along with the what you can do, sunscreens. So any sun protection cream with good coverage. तो आपने देखा होगा 30-50 जो क्रीम आती है ना, सो सन प्रोटेक्शन क्रीम। कौन से अल्ट्रावायलेट की कवरेज ज्यादा होनी चाहिए, यूवीए या यूवीबी? UVA, because UVA goes deeper, stimulate the melanocyte. So good ultraviolet A coverage. It should be have a good ultraviolet A coverage. Second medicines है hydroquinone and the kojic acid. So remember these two medicine. What they do, they inhibit our enzyme tyrosinase, and by inhibiting the enzyme kojic acid, I will decrease the synthesis of melanin. So hydroquinone, there is one regimen, hydroquinone, isotretinoin with topical steroid. If any patient has a extensive darkening of the skin, I can use this free drug. This regimen is the Kligman regimen. Okay. Clinical. नहीं, हमें पता, देखो कंफर्म नहीं करना है, ये तो हमें पेशेंट को तो क्या बताना है, बेटर प्रोग्नोसिस बताना है। अगर ठीक नहीं हुआ तो अब हमें पता चलेगा कि ये तो नॉर्मल था, क्योंकि अगर चेहरे पे बाल करना जाएंगे तो स्टार बना देंगे। तो ये तो जस्ट हिस्टोलॉजिकल फीचर है, पर जिसमें इन्वेजिवनेस जरूरी नहीं है तो करेंगे। सेकंड इज अ मेलानोसाइटिक नेबस। हाँ, if we are giving these three medicine all together, this regimen is a Kligman regimen. ये Kligman regimen, ठीक है। Melanocytic nevus, you just have to remember this image. As you can see, there is a hyperpigmented skin along with the increased hair on this area, right? So you all have seen the nevi, right? So what are the nevi? Nevi are the cluster of melanosome. These are the cluster of melanosome. And the reason of, because of this, what is the side effect is, if this melanoma cluster is very large, in larger area, there is a risk that this patient can develop a melanoma. The reason is they can develop melanoma. So remember this image-based question, they can ask you image along with some MCQ points. So it is a melanocytic nevus. It is a melanocyte cluster. But if it is more than 20 centimeter area, means more than large, so 20 centimeter square area, then there is a risk of conversion into the melanoma. Risk of conversion into melanoma. In which disease you will see the blue color sclera? Osteogenesis imperfecta. Why in osteogenesis imperfecta we see blue color sclera? It is a defect of collagen. हमारी आंख में क्या है? Vessels है. So in normal person we cannot see this blood vessel. अगर आप अपने blood vein superficial देखो तो bluish color की है. It is of the slightly bluish color. So what happens if the collagen is thin? What will happen? When I'm looking from the side, my vein of eye can be easily visible. That is why in osteogenesis imperfecta there is a blue color sclera. Second blue color sclera you should remember is the nevus of Ota. Ab nevus of Ota, how you will remember? From the O you will remember ophthalmic involvement. From the O, ophthalmic involvement. So what happens in nevus of Ota? In nevus of Ota there is a unilateral congenital hyperpigmentation. It is a congenital hyperpigmentation along the trigeminal nerve. It is along the trigeminal nerve. And on that same side, you will see eye involvement, blue color sclera. So skin involvement to hai, along with that, blue color sclera is also there. If you can appreciate here also, there is a hyperpigmentation on this area. Okay. So patient is having a hyperpigmentation of skin along with the eye also. So it is a nevus of Ota. Congenitally on a nervous tissue, there is a hyperpigmentation. Now, if they ask what is the treatment, so nowadays we have a laser treatment. So laser से क्या करेंगे? We will remove melanocyte with the use of the laser. So they don't ask the treatment which are on the laser, but it can be treated. Second is a same thing, but it is a nevus of Ito. So nevus of Ota and Ito, it is a similar, pathology is a similar like news of Ito, similar like news of Ito, sorry, Ota. Ito and Ota are same, but location is on the upper back. Location is on the upper back. So these are the hyperpigmented nevi. Okay. See this. This news was asked in your exam. But what is the peculiarity of this nevus is hair. You will see increased hair on that area. So why hair is increased? Along with the hyperpigmentation, this area is also having a increased androgen sensitivity. And because of this person will have a increased hair. So you can easily identify Baker's nevus, right? Baker's nevus is also the melanocyte cluster. It is a melanocyte cluster along with increased androgen sensitivity. And because of this, in the affected area, you will see hair and acne is increased. If the person has acne on the face, he will also have acne in this area. In which news? In news of it, bluish black crystals. ईटो में आइस इन्वॉल्वमेंट नहीं होगा ना, इसीलिए तो वहां पे हमने क्या याद रखा, नेव्स ऑफ पोटा ओ फॉर ऑप्थेल्मिक इन्वॉल्वमेंट. ईटो में चेहरे पे नहीं होगा बट बैक पे होगा. सेम नर्व इन्वॉल्वमेंट नहीं, बट नॉर्मल जो डर्माटोमल इन्वॉल्वमेंट है वही पर. ओके. मोंगोलियन स्पॉट, उसमें हमें ऑप्थेल्मिक में याद रखना है ट्राइजेमिनल नर्व के एरिया में. Mongolian spot. You all know Mongolian spot, right? What is the cause of Mongolian spot? So normally हमारे melanocyte, which is coming from the neural crest, is on the basal membrane, right? Above the basement membrane. But what happens in Mongolian spot? Because of the immature abnormal migration, it is releasing the pigment below the basement membrane, and because of this we have a bluish discoloration in this area. But as soon as after 3-4 or some 1 year, when this melanocyte come here at normal place, child will not have this rash. So this is only during for some period. So that is why Mongolian spot is not a permanent rash, it is a benign rash, right? So just remember, it is a failure of the migration of melanocyte from the neural crest. So when the melanocyte will acquire the normal place, you will not see this rash. So Mongolian spot is a benign rash. Okay. So we have been talking about this mucosal staining, right? So this is the mucosal staining, as you can see in this child. This child is having a skin pigmentation also here. You can see skin pigmentation along with on a lip. You can see this mucosal staining. And if you see the buccal mucosa, on buccal mucosa also you will see this black color pigmentation. Along with this, in your exam, they will give you the history that this patient is having a chronic diarrhea or endoscopy or colonoscopy. He was found to have a small multiple intestinal polyp. Okay, so it is a Peutz-Jeghers syndrome. Jaeger syndrome. This syndrome having a mucosal staining intestinal polyps, and increased risk of colon cancer. So later on in life, they have increased risk of the colon cancer. Okay. See this image. So we already wrote it is the salt and pepper pigmentation. Salt and pepper pigmentation. Salt and pepper pigmentation of the scleroderma. In the scleroderma, yesterday I told you scleroderma can lead to Raynaud's. What is the most common cause of the Raynaud's phenomena? Most common cause is एक होगी ये बंद तो पहले नहीं बंद most common cause is the idiopathic what is the discoloration WBR okay so whitish discoloration is a phase of the vasoconstriction. Then patient will develop blue color because of the cyanosis, and when because of the cyanosis and lack of oxygen, when there is an increase the prostaglandin level and nitric oxide level, there will be the reperfusion of the blood, and person will have a redness. Then person will develop the redness. Drug of choice in scleroderma. It is a calcium channel blocker. So you will look for any calcium channel blocker in the option. Topical you can apply nitroglycerin. Topical you can apply nitroglycerin. And avoid cold exposure. Cold exposure should be avoided. Sure. Cheaper. Raindrop pigmentation. Raindrop pigmentation. Arsenic poisoning. Acute arsenic poisoning, chronic arsenic poisoning. Chronic. Because acute arsenic poisoning, what you will see? Acute gastroenteritis. It is like a acute gastroenteritis, acute arsenic poisoning. Whereas chronic arsenic poisoning will cause raindrop pigmentation. So add as a one-liner. It is a chronic, remember chronic arsenic poisoning. Because acute arsenic poisoning cause acute gastroenteritis like feature. Acute will cause AGE like feature. acute gastroenteritis like this, brain drop pigmentation, chronic arsenic poisoning. Moving to next, in this image, what I am trying to say is, by looking at this image, nothing is abnormal, because when you are seeing the patient for the first time, it is not abnormal because you don't know what was the color of his knuckles, right? So this patient himself will come to you that I am having a hyperpigmentation on my knuckle. So you as a doctor, first time you will not notice this hyperpigmentation, but patient will itself complain that I am having a hyperpigmentation, or in his body, wherever the friction is more, she is developing more hyperpigmentation. The reason is of the severe B12 deficiency. So, in which disease you will have a vitamin B12 deficiency? Which anemia? Pernicious anemia. Megaloblastic तो anemia होता है ना? नहीं, मेगालोब्लास्टिक एनीमिया तो मेगालोब्लास्टिक एनीमिया B12 एक रीजन है मेगालोब्लास्टिक में. मेगालोब्लास्ट मींस सेल्स आर लार्ज. मेगालोब्लास्ट उसमें से B12 वन ऑफ द रीजन है, मोस्ट कॉमन होगी. सो B12 deficiency, when there is a decreased B12 vitamin, it causes the diffuse hyperpigmentation. We can notice blackening of the knuckles. So now see this disease. So this is a patient developed this whole body diffuse hyperpigmentation along with the mucosal staining. So this is the image directly taken from the Harrison. In Harrison, they give you this image. So which disease can cause hyperpigmentation like this all over the body diffuse? It is a Addison's disease. This is a Addison's disease. Along with this, in Addison's disease, they will give you a clinical picture or a description like this, that the patient is having a hyperpigmentation along with because of the low aldosterone. What will be the symptom of the patient? Patient will have a decreased blood pressure. What is the function of aldosterone? Sodium retention and potassium excretion. If aldosterone is less, what will happen? Hyponatremia. Along with what I can do, hyper. So this feature they will give you. This feature they will give you. तो aldosterone कौन से लेयर से सिक्रेट होता है? एड्रेनल ग्लैंड कॉर्टेक्स से सिक्रेट होता है ना? कौन से लेयर से सिक्रेट होता है? 3 लेयर है ना? GF, ग्लोमेरुलुला, fasciculata, reticularis. GF from the glomerulula, salt, sugar, and sex. So salt means mineralocorticoid. So mineralocorticoid is which hormone? Aldosterone. Sugar means glucocorticoid. Which hormone? It is a cortisol. And sex hormone, dihydroepiandrosterone. So from the outer cortex, G, F, and R, and then comes the medulla. Which hormone secreted from the medulla? Epi and norepinephrine. So मेडुला के ट्यूमर को क्या कहते हैं? अगर यहाँ पे ट्यूमर हो जाए तो व्हाट इज अ ट्यूमर? इट इज अ फियो, राइट? यहाँ पे ट्यूमर हो जाए तो इट इज अ कॉर्टेक्स में ट्यूमर है, कौन सा सिंड्रोम? अगर कॉर्टेक्स डिस्ट्रॉय हो गया, कौन सा डिजीज? एडिशन डिजीज, राइट? सो नाउ टेल मी, if there is a destruction of the cortex, which hormone has a regulation on the pituitary gland? Cortisol. You all know pituitary adrenal axis. Which hormone is the regulator? Cortisol. What will happen? See this. This physiology is very important, and multiple times they ask this. So this is my pituitary secrete which hormone? ACTH. ACTH will stimulate the adrenal gland, right? And this adrenal gland, cortisol, has a negative inhibition on the pituitary. So if in my body cortisol is low, what will happen? There is a constant positive stimulation of the pituitary, and because of this pituitary has to increase the ACTH, right? But how this ACTH is formed? ACTH is formed for the pro-opiomelanocortin. It is a pro-opiomelanocortin. So कैसे बनता है? Pro-opiomelanocortin is divided into ACTH and the MSH. So what is happening? If my pituitary required to secrete more ACTH, what will happen? By forming the ACTH, there is also a byproduct which is a MSH. So what will happen? This ACTH will try to stimulate my adrenal gland, but this increased MSH will go into the body, and what it will cause? It will cause diffuse hyperpigmentation. It will cause diffuse hyperpigmentation. Clear? याद क्या रखना है? How the ACTH is formed. तो इसे बता दो. See this. यहाँ से चालू करते हैं. Pituitary secrete which hormone? ACTH. To stimulate which gland? Adrenal gland. Adrenal gland secrete, as I told, aldosterone, cortisol and DHEA, dihydroepiandrosterone. कैसे याद रखोगे? Mineralocorticoid is aldosterone. Sugar means glucocorticoid. Which hormone? Cortisol. Sex hormone, dihydroepiandrosterone. But which hormone is the regulator of this axis? It is a cortisol. If my adrenal gland is making enough cortisol, it will send a negative signal on my pituitary that don't send ACTH. Don't send ACTH. My amount is adequate in the body. But what is happening in Addison's disease? There is an autoimmune destruction or a tuberculosis-led destruction of the cortex. So, because of the destruction, what is happening? There is no enough cortisol. So, what is happening? My pituitary is sensing that there is no enough cortisol. So, what it will do? It will try to increase the synthesis of ACTH. ACTH बनता कहाँ से? Pro-opiomelanocortin. So, when I am using this nucleus to synthesize ACTH, what this nucleus is doing? आपको पता है hormones कैसे बनते हैं? I will cut the peptide chain. And cutting the peptide chain, I will use this as a hormone. And because of this, I'm forming one hormone, ACTH, for the stimulation of which gland? Adrenal gland. Along with that, I have formed one hormone which is a melanocyte stimulating hormone. And this melanocyte stimulating hormone will go in the body and will cause diffuse hyperpigmentation. So यहाँ पे हमने बहुत सारे डिजीज एक साथ देख लिए. कौन सा सिंड्रोम क्या है? ट्यूमर है. adrenal cortex की. So it will lead to hyperaldosteronism, right? Pheochromocytoma क्या है? It is a tumor of adrenal medulla. क्या है डायग्नोसिस, क्या करते हैं फियोक्रोमोसाइटोमा में? यूरिन में बाई प्रोडक्ट्स देखेंगे एपिनेफ्रिन की और नॉरएपिनेफ्रिन की. क्या है वो? होमोवेनिलिक एसिड और वेनिलिल मेंडेलिक एसिड, HME और VME. सो ये देखेंगे. ड्रग क्या देंगे उसमें फियोक्रोमोसाइटोमा में? ऐसे याद रखते हैं. पहले आता है ना A बिफोर B. मतलब आगे कौन सी मेडिसिन यूज करते हैं? फिनोक्सी बेंजामिन. करने के लिए क्या देंगे? बीटा ब्लॉक. ऐसे याद रखना है. फियोक्रोमोसाइटोमा में कॉमनली ये ट्रीटमेंट पूछते हैं. ए बिफोर बी, इट इज अ फियोक्रोमोसाइटोमा. हमें एडिशंस का पता चल गया. अब एडिशंस में क्या देंगे? बाहर से आपको स्टेरॉइड देना है. एडिशन की ट्रीटमेंट ये है कि बाहर से स्टेरॉइड देना है. अगर बाहर से स्टेरॉइड देंगे तो अपने आप मेलानोसाइट स्टिमुलेटिंग हार्मोन बनना बंद हो जाएगा. चल हाँ ऐसे diffuse form of a hyperpigmentation. It causes vitamin B12 deficiency, ACTH secretion already told, right? And Whipple's disease can also cause diffuse hyperpigmentation. So all of above. So there are many diseases in dermatology which cause hyper. Langerhans cells are derived from the bone marrow. They are derived from the bone marrow. It has a granule which are known as a Birbeck granule. So MCQ पूछते हैं. Birbeck granule are the tennis racket shaped granules. It is a tennis racket and these are the antigen presenting cells in the skin. These are the antigen presenting cells in the skin. So see this, these are the rock tennis racket shaped granule. तो एक दूसरा क्वेश्चन पूछते हैं मेडिसिन में कि इन विच डिजीज देयर इज इंक्रीज्ड टेनिस रैकेट शेप्ड ग्रैन्यूल. सो आंसर इज हिस्टियोसाइटोसिस. इट इज इंक्रीज्ड इन histiocytosis. Okay, Langerhans cells में इतना याद रखना है. Next are the Merkel cells. Merkel cell also is found among the basal keratinocyte. So the location is the basal cells seen among the basal cell. And these are acting as a slow adapting touch receptor. These are acting as a slow adapting touch receptor. Slow adapting touch receptors. बस दो लाइन ही इसमें, तो सी दिस तो ऐसा क्यों दिख रहा है इसमें? अब आया, अब आ गया. What is this disease? It is not clearly visible in your screen, but if you can see, there is a hyperpigmentation in the nape of the neck and the axillary area. There is a thickening of the skin. So, what is the histological feature of this? What will be the histological feature? Patient have a acanthosis. When there is an increase in the thickness of the skin, this disease is known as the acanthosis nigricans. Acanthosis means increase in the thickness of the layer stratum spinosum, and nigricans means darkening. This condition is associated with glucose intolerance. So, in which disease you see glucose intolerance? The most common is a. Any other disease in which you will see glucose intolerance? If the person has a Cushing's disease or Cushing's syndrome, there is a steroid excess. तो स्टेरॉइड में कौन सा हार्मोन है? ग्लूकोकॉर्टिकॉइड हार्मोन है. तो ग्लूकोकॉर्टिकॉइड का काम क्या है? ग्लूकोज को बढ़ाना. So there will be always glucose will be high in the Cushing syndrome. That is why the patient lead to excessive obesity, right? So any kind of Cushing's or this steroid excess can lead to acanthosis nigricans, Cushing's or the steroid excess. But they ask which cancer is associated with the acanthosis nigricans. Answer is a gastric adenocarcinoma. It is a gastric adenocarcinoma. Yeah. Steroid excess. Any disease which causes steroid excess. But commonly they ask, because this is a atypical presentation of cancer, so they ask which cancer is associated. It is a gastric adenocarcinoma. Okay. We will discuss disease of the desmosome. See this image. So I am showing you the image of a desmosome. So as you can see, desmosome is made up mainly of a three important proteins. There are many protein involved, but three important protein along with the calcium. So we discussed two disease which has a calcium pump defect in acantholysis. That was the Darier's disease and the Hailey-Hailey disease. In Hailey-Hailey disease, as you can see, this desmosome is dependent on the calcium. If there is a defect of the calcium pump, this connection will get weak, and what will happen? Two cells can separate. Along with this, as you can see, there are this protein, and this protein also. So what are these protein? We will write down. So desmosome is made up of three important proteins. Three important proteins. These are the desmoglein. This is the desmoglein. Desmoplakin. And the desmopolin. Desmoglein, desmoplakin, and desmopolin. If the person develop a pemphigus, so there are two types of pemphigus. One is a IgG induced pemphigus, in which patient has a antibody against desmosome, right? In pemphigus, we have a antibody against desmosome. What happens in this disease? Desmoglein is damaged with IgG antibody. So my IgG antibody will destroy this desmoglein protein, which will lead to desmosome destruction. And if this destruction occurs, patient will develop blister. Patient will develop blister. These IgG pemphigus can be of two varieties. Pemphigus foliaceus Pemphigus vulgaris. Pemphigus foliaceus, Pemphigus vulgaris. In this, they ask important MCQ. Pemphigus foliaceus cause subcorneal blister. It causes subcorneal blister. Whereas these will cause suprabasal blister. So meaning subcorneal means accumulation of the fluid will be just below the stratum corneum. Suprabasal means above the basal layer. This is suprabasal blister. The second variety, it is a IgA pemphigus. In IgA pemphigus, IgA antibody against the desmoglein. IgA antibody against the desmoglein. Against the desmopolin. And in the cancer or the paraneoplastic condition, if the patient has a paraneoplastic condition, or any cancer present in the body, and if they develop pemphigus. So because of these, if patient develop pemphigus, in this pemphigus, the main protein which is destroyed is a desmoplakin. Desmoplakin is main, but along with the desmoplakin, this patient can have a destruction of desmoglein also. But exclusively desmoplakin is destroyed. ये मैं बता रहा हूँ, ये जो है ना, इसमें आपको एक याद रखना है, because the desmoglein, but if they ask as a one-liner, which is a because of the cancer, what you will answer? Desmoplakin. Cancer में क्या होता है? It is attacking all epidermis. So तीनों protein involved हो सकते हैं. But which protein is mainly involved? Desmoplakin is mainly involved. Desmoplakin, you will remember for the paraneoplastic. For the paraneoplastic, remember desmoplakin. Most of the important is the desmoglein only. For your exam point of view, what I think is they will ask you IgG pemphigus, and in IgG pemphigus, you remember desmoglein. This is more important. So even if you don't remember other one, don't worry. Remember, don't forget desmoglein, because this will be asked. They will not write anti-desmosome antibody, but they will write anti-desmoglein antibody. Okay. So when we talked about the acantholysis, right? We talked about two types of acantholysis: primary and the secondary. In primary, what was the example? One is the pemphigus vulgaris, right? And the staphylococcal scalded skin syndrome. Why in staphylococcal scalded skin syndrome? Because epidermolytic toxin. This toxin will damage the desmosome, and two other diseases which were, yes, primary acantholysis. We will be talking about the calcium pump defect disorder due to calcium pump. Primary acantholysis due to calcium pump is seen in a Terrier's disease, and the Hailey-Hailey disease. Terrier's disease and the Hailey-Hailey disease. Okay, we will discuss the first Terrier disease. In the Terrier's disease, first of all, understand these are the cells of the desmosome, has a tight desmosome connection, and because of the calcium pump defect, it will lead to weak desmosome, and because of this weak desmosome, this cell will become round shaped cell. But as we discussed in the first class, what is the two important strength of my keratinocyte? keratin filament, and these are desmosome connection. So what is happening in Darier's disease? In Darier's disease, these cells are sensing that I am having a weak desmosomal connection and I might get separated from the other keratinocyte. And so as a compensatory phenomena, what they are doing to get attached, they try to increase in the keratin filament. And by doing this, what they want to have a tight connection which are other than the desmosome, right? So because of this, when this cell reaches the uppermost layer, when this cell reaches the uppermost layer, which is a stratum corneum. So because of excessive keratin, because now too much keratin is present on the stratum corneum, patient will now have a complaint of hyperkeratosis. So what will be the patient's complaint? That doctor, I am having a papules on my body. So these are the hyperkeratotic papules. Patient will present to you because of the hyperkeratotic papules. Because this
जाओ एंट्री कर लो जाओ तुम एंट्री कर लो
student, please mute yourself.
ऐसे तो तुम सीखोगे तुम्हें तो सीखना था
ये तो मुझे आता था मैम
पहले पढ़ाई कर लो
ये तो
नहीं सीख करनी है ना उधर
This is known as a premature keratinization, or in other term, it is a dyskeratosis. So what is the feature of Darier's disease? The dyskeratosis and the hyperkeratosis. So remember this histological feature: dyskeratosis and the hyperkeratosis. If this dyskeratosis, when this dyskeratosis, if you see this dyskeratosis in the stratum corneum, which is mainly the flat cell layer, this finding is known as a corpse grain. And if it is involving stratum granulosum, it is known as a corpse rond. So as you can see in this disease, there is an increased keratin filament. The treatment is the keratolytic drugs. Treatment is a keratolytic drugs. Stratum corneum, stratum granulosum. So because of this, as you can see, what happened? Because of the weak keratinocyte, there was a compensatory phenomena. Which was the compensatory phenomena? Increased the keratin filament. So that is why this disease is also known as a keratosis follicularis. The another name of this disease is a keratosis follicularis. So from this name, you can remember like this: this patient is having a hyperkeratosis dyskeratosis. They are having a hyperkeratosis and dyskeratosis. Okay. चलो और नेक्स्ट डिजीज है हेले हेले डिजीज। अब हेले हेले डिजीज में कुछ याद नहीं रखना है, इतना याद रखना है दोनों में कैल्शियम पंप डिफेक्ट है, बोथ द डिजीज हैविंग अ कैल्शियम पंप डिफेक्ट, but these various disease has some compensatory phenomena of hyperkeratosis or dyskeratosis, and because of this the gap between two cells are not larger because the strength of the keratin filament was retained because of the increased keratin filament, so there was no enough space that the patient is developing any fluid filled vesicle or a fluid filled bulla. Right, as you can see, the only problem in this patient is the patient will complain of a hyperkeratotic capsule. So I will show you the image to see this. This is the patient who will complain that on my all over the body I am having a very rough skin, and if you touch you will see the tiny capsule. So what was the capsule? Above the skin, less than 1 centimeter, and you will see and you will be able to feel above the skin. So these are the hyperkeratotic capsule all over the body. But what happens in hele disease? See this image. In hele disease, desmosome connection are weak because of the connection of the calcium pump. Calcium pump defect is there, so weak connection. But what is happening in the localized area? There is no compensatory mechanism. So if there is no compensatory mechanism, what will happen? Cell will get separated, and after the separation, fluid will accumulate, and this fluid will accumulate and will cause inflammation. So this patient will present with a exudation. Can you see? This patient is having a fluid oozing out from the skin. So in the hele disease, just you have to remember like this. In hele disease, there is no compensatory phenomena. So second disease, sorry, is papule. Sorry, hele disease. It is a plaque, patch when it is not raised above, but when it is above the rise, it is a plaque. So you can say it is a plaque. Exudate is there, but this exudate is not a pus. This exudate is not pus. It is like just because our body generally we have skin. That is why the fluid is not coming out from our body. But if all the skin pore gets open, we will be losing the fluid physiologically also, because there are blood vessels. So skin is protecting us like this, but the protection is lost because of the separation of the epidermal cells. In hele disease, due to weak desmosome plus no compensatory phenomena, no compensatory hyperkeratosis, this will lead to separation of keratinocytes. Patient will present with blister or the plaque with the exudation. So this can get, if they are infected, it can produce exudation also. So if transudation, when the fluid is oozing out. So when we say exudation, if the infection is involved. So if it is a clear liquid, no infection, then it is a transudation. It is just a matter of what is going on in there. But the thing is, there is a abnormal inflammation will start because of the separation of the two epidermal cells. Because the area is open, any infection can enter here. So the gene defect they ask is a calcium ATPase 2C1 gene. In the Hailey-Hailey disease, the gene which is involved is a calcium ATPase. So you can remember like this, it is a calcium pump defect. So calcium ATPase defect. Two C1. Okay. Second abnormality, weak keratinocyte. So see this weak keratinocyte due to genetic defect of the keratin filament. Genetic defect of the keratin filament. So see, if my desmosome connection is strong, but keratin filament which are inside this cell, if they are weak, what will happen? Person will develop on minimal trauma. This keratinocyte will get ruptured. So trauma-induced blister. Patient will develop a trauma-induced blister. So can I say acantholysis here? It is no acantholysis, right? It is a direct rupture of the keratinocyte. So no acantholysis. So how to differentiate? How to differentiate this disease? I will do direct immunofluorescence. Direct immunofluorescence. On direct immunofluorescence, if it is positive, so what is meaning the positive is, so on my keratinocyte, because which antibody is getting accumulated to destroy this desmosome? It is the IgG antibody. So what I will do on a direct immunofluorescence test, when I add the dye, it will bind this all antibody which is deposited on the keratinocyte, and when I put some dye to illuminate this dye, this will give me a fishnet pattern. This will give me the fishnet pattern. So if I get a fishnet pattern, means in my body there is an desmosome antibody present. So in this case, I will get to know that this patient is having a pemphigus disease. So see this is the fishnet pattern. So this image-based question has been asked. So why we are getting fishnet pattern? Because this desmosome are present on the keratinocyte. These are the polygonal shaped cells. So this antibody is depositing on the keratinocyte. And that is why you will get a fishnet pattern. And if this fishnet pattern is not present, so if my antibody is against the desmosome, what will be the pattern? Hemidesmosome. If antibody is against the hemidesmosome, hemidesmosome is on the basement membrane, right? So these two important MCQ they ask linear deposition on a direct immunofluorescence. Which disease? Bullous pemphigoid. Bullous pemphigoid, which antibody form? Against the hemidesmosome, right? Whereas fishnet pattern, antibody against the desmosome. That is why the pattern you will see is a fishnet pattern, right? So this is the association you should know. So, but what I'm trying to say here, if my direct immunofluorescence is negative, see, if my direct immunofluorescence is negative, then I have a weak keratin filament. The reason of the rupture of my keratinocyte is a weak keratin filament. And this disease is a epidermolysis bullosa simplex, EBS. So for the epidermolysis bullosa simplex, you should remember that if I do the direct immunofluorescence test, it will be negative. Why? Because there is no any antibody is involved. Itself keratinocytes are weak. Itself keratinocytes are weak. Okay. Next topic, sweat glands. Sweat glands are mainly of two types. These are the acrine sweat gland and the apocrine sweat gland. Acrine sweat gland and apocrine sweat gland. The difference of the acrine is this gland directly open. This gland directly open on the skin surface. This directly open on the skin surface. Whereas apocrine sweat gland open on the hair follicles. So these glands open with the hair follicle. So in your body, where you will see eccrine sweat gland, eccrine means everywhere. Remember like this, eccrine means, so it is just a hack to remember, eccrine everywhere. You will find this gland all over the body. You will find this gland all over the body. Second is the apocrine gland. A for axilla, areola, and the perineal area. Perineal area. Why? Because you all know in axilla and perineal area, this area is associated with the puberty. Because these glands are under the adrenergic control, you will see that development of this gland later during the puberty more when this hair increases. Okay, we will write down few points on a eccrine sweat gland. It is under एपोक्राइन, एक्सिला और पेरिनियल एरिया में बाल कब आता है, प्यूबर्टी के साथ साथ आता है. सो बिकॉज दिस ग्लैंड इज अंडर द एड्रेनर्जिक कंट्रोल, so along with the puberty you will see that there is an increase in the apocrine glands. So it is just to remember the location and the function of this gland. Eccrine sweat gland is under sympathetic cholinergic control. If I get an obstruction of this eccrine sweat gland, disease is known as a miliaria. The disease is known as a miliaria. And the hyperfunction of this gland is a hyperhidrosis. This is a hyperhidrosis. This gland is under the adrenergic control. Under the adrenergic control. In the two gland, mammary gland and the moles gland, these are considered as a modified apocrine gland. So the MCQ asks, what are the modified apocrine gland? It is a mammary gland and the moles gland. If there is an obstruction, it will cause two important diseases. One is a hydradenitis suppurativa, and the second is a Fox Fordyce disease. Second is the Fox Fordyce disease. Okay. So I will show you the photo of these two diseases. See this. The first disease, it's a Fox Fordyce disease. As the name suggests, there is no any inflammation. But in hidradenitis suppurativa, the name is telling you there is a hidradenitis, right? So hidradenitis, how you can differentiate? So first of all, they will give you the photo of axilla or the perineal area if they want to tell you about the some disease. So when you will Google this disease, you will see the photo of axilla, and because this is a disease of the apocrine gland. So how you will identify? You will identify that there is an inflammation and the pus discharging sinuses. So these are the area of pus discharging sinuses because there is a abscess or pus formation. So what is the reason of this is there is an obstruction of this apocrine gland. In which other disease you will see the same pathophysiology of obstruction of the gland which can lead to the inflammation of the area? Any disease you know with the same pathology? What is happening in acne? Acne also the disease of a keratin plug obstruction, but the gland is a which gland? Pilosebaceous gland. But here hidradenitis suppurativa is causing the obstruction of the apocrine gland. So pathology is same in a hidradenitis suppurativa and the acne, and because of this disease is also known as the inverse acne. Inverse acne. So we will write out few important points on this. Hidradenitis suppurativa. Hidradenitis suppurativa. It is a sweat gland inflammation mainly apocrine gland in the axilla and the perineal area. Due to keratin obstruction. Due to keratin obstruction of the apocrine gland. That is why this is known as the inverse acne. This is known as the inverse acne. Treatment is that is why retinoids. So what is the function of retinoid? These will act as a keratolytics. So this will act as a keratolytic. For the inflammation, you have to use antibiotics to treat the infection. And you have to give the drainage if the abscess is large. एक्ने में भी हम यही ट्रीटमेंट देते हैं ना, we give keratolytics, we give antibiotics, right? because pathogenesis is same. In fox spotted disease, you just have to remember that image. In fox spotted disease, there is an obstruction, but this obstruction, what it will do? It will destroy that hair follicle and will only left with the inflammatory capsule without any inflammation. So no inflammation in fox spotted disease. No inflammation present. Only you will see inflammatory papule. In the apocrine gland area. So general treatment is not required. Because this disease will not increase, it is just a obstruction, it can get resolved on its own. Okay. Okay, now answer this question. Zangsmeer negative. यार ऐसे भी कर रहा है. In which disease you will see Zangsmeer, in which there is a separation of two keratinocytes, right? So in Hele disease there are weak desmosomal connection, so you will see Zangsmeer. Yes. In pemphigus there is an antibody against it, so you will see. In herpes you see secondary acantholysis, but bullous pemphigoid is an antibody against the hemidesmosome, so you will not see Zangsmeer. Got my point? Okay. See this. कार्डिनल फिनोमेना, कल बात की थी. कार्डिनल फिनोमेना कौन सा डिजीज बात की थी? 3 डिजीज बात करेगी. The 3 disease which are the autoimmune: psoriasis, lichen planus, and the vitiligo. These are the 3 diseases which shows the cardinal phenomena. So psoriasis shows cardinal phenomena. So let's write down cardinal phenomena. If you can see in this image, in dermatology, remember like this. If they give you the flexure area, a photo of the flexure area, what is the most common disease you will see in the flexure area? Is the lichen planus. If I am giving you the photo of the extensor area with the silvery scale, this is most likely the photo of the psoriasis. Because in psoriasis, most commonly the extensor surface is involved. In lichen planus, flexure is involved. So as you can see from this watch, this is the flexure area, wrist area. As you can see, this is the cardinal phenomena example. So this was the primary lesion. But because these lesions are itchy, patient itches this area, and after this, as you can see, a similar lesion started appearing on the line of my scratch. This phenomena is seen in a psoriasis, lichen planus, and vitiligo. Okay, so you write down cardinal phenomena. On a linear trauma, if you have a similar lesion, so this is my primary lesion and these are the secondary. These are the same as the primary. These lesions are the same as the primary, And because of this phenomena is known as the isomorphic phenomena. This is an isomorphic phenomena. But this isomorphic phenomena or the Koebner phenomena, it is a true phenomena. It is a true phenomena in case of psoriasis, lichen planus, and the third is the vitiligo. So true isomorphic phenomena. But there are some example of false phenomena also. So what is false phenomena? Suppose this is my primary lesion of the viral infection. So this lesion is harboring many viruses inside this. But when I itch, what will happen? I will inoculate this virus on a line of my scratch, right? Wherever I will itch, I will inoculate this virus on the healthy skin. And because of this, what I will see, a similar lesion start appearing around the primary lesion. But what is the cause of this lesion? The cause of this lesion is a viral inoculation, not the autoimmunity. And that is why this is a false isomorphic phenomena. The example of the false isomorphic phenomena is a molluscum contagiosum. So what is the positive of molluscum contagiosum? Which virus causes molluscum contagiosum? Pox virus. Warts is caused by the human papillomavirus. It is caused by the human papillomavirus. Warts is caused by the human papillomavirus. Third, you can easily remember. See this rainbow. So what is this rainbow? If you read it in the reverse, what is it? It is a powder. So rainbow phenomena is also known as a reverse Koebner. It is a reverse Koebner. Just one liner. It is seen in psoriasis. It is seen in psoriasis. So sometimes what happens after the linear trauma, the size of the primary region reduces, not increases. So it is a reverse Koebner phenomenon. So rash is reduced, then it is a reverse Koebner phenomenon. So generally in Koebner phenomena, rash increases, right? But in reverse Koebner phenomena, rash decreased. Rash decreased. Rash will decrease. That is a reverse Koebner. Now you can identify what is the answer. Isomorphic phenomena is a feature of all except. Answer is a tinea. It is not a feature of tinea. We will discuss dermatological lines. The first important line is the Langer's line. So see this, what are these lines on our body? On our body, there is a collagen deposition. When the skin is forming in the dermis area, there is a deposition of collagen. And this collagen deposition has a stretching like this. Why this is important is, it is important to make a surgical incision. So if you make across like this, if you make an incision across, what will happen? Because you are cutting down the collagen fiber. Now, when will be the wound healing? It will be healed with the hypertrophic scar. So if you are making a scar like this, incision like this, what will happen? There will be the minimal hypertrophic tissue. So that is why you should remember what is the importance of the Langer's line. The two important, it is a line of skin tension. It is a line of skin tension. Of the collagen fiber. It is the orientation of the collagen fibers. Incision should be made along this line, and if made across, if this line is made across this line, there are the chances of developing hypertrophic scar. There is a chances of developing hypertrophic scar. Okay, these are the Langer's line. Next series example. Okay, see this image. This patient developed this vesicle rash. So this is a vesicular rash patient developed when he had a typhoid fever. Along with the typhoid fever, he developed this rash. As you can see, what are these lesions described? Anyone know what is this disease? It is a herpes zoster. So why herpes disease is known as a zoster? You all know varicella chickenpox, right? So when person is having a chickenpox, you all know the lesion or vesicle is all over the body. Fluid filled vesicle, बच्चे में जब होता है, it is all over the body. But what will happen once the patient gets treated? This bacteria will go into the dorsal root column of our spinal cord. So what are these dorsal root? These are the dorsal root which innervate our skin all over the body. From the scalp, if you start, this is the C2 segment. So from the cervical, I have a superficial nerves which are stimulating my skin. C3, C4, C5. So these are the dorsal root. You all know spinal cord is giving away dorsal root and anterior root, and then it is innervating my skin. These are the area which is innervated by the particular spinal cord level. These are known as a dermatome. Right? These are the dermatome. You all know. So these are the dermatome which is a C6, C8, T2, T4, T6, and all. So what will happen? This virus, suppose this virus go to the T3 level of the dorsal root. So after the chickenpox infection, this virus is hiding in the T3 dorsal root column. And as soon as this patient has some immunocompromisation, like patient is having another disease. So because my immunity is keeping a check on this virus that do not come out. But what is happening if suppose some other bacteria is in my body? In typhoid fever, Salmonella type is there. So my immune cells are going there to kill that bacteria because this bacteria is all over the body. So this virus will sense that there is no guarding here. So what they will do, they will start coming out. And when they start will coming out, it will come up in the area of the innervation of that nerve. Got my point? So that is why this region is known as known as a zoster. The meaning of zoster is this region is on the dermatomal line. And because of this disease is known as the herpes zoster. Okay, so we will write down this second line, which is a dermatomal line. Dermatomal line. So dermatome is always corresponds to spinal nerve root. It corresponds to the spinal nerve root. It is a nerve of skin innervation. So nerve to skin innervation. When there is a primary infection of the herpes virus, which virus caused? Varicella? Varicella zoster virus, right? Why varicella zoster name is given? It has a two component. The first component, which is a varicella. Varicella is a diffuse. Vesicle are the diffuse. Second component of this virus is a zoster. Means patient will have a zosteriform lesion. The meaning of zosteriform is involving single dermatome. When the single dermatome is involved, it is known as a zosteriform lesion. Okay, so these are the important dermatomal lines. Third is a Blasco's line. Blasco's line. Third is a Blasco's line. These are the line of embryological development. These are the line of embryological development. So it is an embryonical derivative. It is not commonly seen on our body. It is just a representation of an embryological development of our skin. But if in some disease, I will show you the photo of this disease. It is an incontinentia pigmenti. In this disease, what happened? There is a hyperpigmentation on the line of the Blasco. Okay, so then only these lines are visible. Otherwise, these lines are not visible. In your FMGE exam, this MCQ was asked that the line of the Blasco represent it is a line of the embryological development. So, what are the line of nerves? These line are the dermatomal line. What are the line of collagen fiber? Langer's line. These are the line of the Langer's. But remember, these lines, blastose line, are the just embryological derivative. There is no underlying nerve, blood vessel, or the lymphatic. So no relation to any nerves, blood vessel, or the lymphatics. Sure. Line of Glasgow, it is a line of embryological development. Line of line of nerves carry dermatomal line. And if I say line of the collagen fiber, these are the Langer's line. So see, Nikolsky sign. What is Nikolsky sign? Nikolsky sign is a separation of epidermis and the dermis. So can you see, if my epidermis and dermis is separated, which structure are likely to be disturbed? Desmosome, mainly the desmosome, because the strong connection is mainly the desmosome. So either, so see this, when we so let's see this. So this is my epidermis. On this epidermis, if there is a rupture, of my keratinocyte, what will happen? This part of the epidermis will be separated from the dermis. If there is a destruction of this basal keratinocyte for some reason, what will happen? This part of the epidermis, which is a stratum corneum, and some part of the lucidium will get separated from the dermis. So we discussed this in which there is a weakness in the keratin filament. What was that weakness? Epidermolysis bullosa. So there was a genetic weakness in the keratin filament. If I have a Derriers disease, what will happen? I will get a blister here, right? But because the compensatory mechanism is present, the fluid will not be there. But what will happen in pemphigus? In pemphigus, there is a damage to the desmosome. What will happen? I will have a round keratinocyte like this, and because these cells will get round shape, a fluid will start accumulating here, and ultimately, collectively, I will develop a fluid-filled bulla or vesicle, right? So because of this fluid, what happened? My dermis and epidermis get separated because of this fluid. So Nikolsky sign, how to elicit this sign, I will show you. So see this, I am giving a slight pressure on my epidermis, but as you can see in this image, there is a rolling of the epidermis. Can you appreciate this rolled over epidermis here? I am giving a slight pressure. So this sign is the Nikolsky sign. So always remember, Nikolsky sign is just by giving a minimal pressure, I am having a separation of the two layers of the skin, which is a epidermis and dermis. So separation of epidermis and dermis on a tangential pressure. By giving some tangential pressure, I have a separation of epidermis from the dermis. This Nikolsky sign is a true Nikolsky sign. True Nikolsky sign when acantholysis is present. when I have a acantholysis present, it is considered as a true sign. So in which two important diseases you will see acantholysis? The first is the pemphigus. In pemphigus, I have a anti-desmoglein antibody, right? Anti-desmoglein antibody. Second is the staphylococcal scalded skin syndrome. In this, I have a epidermolytic toxin. This toxin damages desmoglein, right? So because I have a anti-desmoglein antibodies present or toxin is present, I will have a positive true Nikolsky sign. The second is a false Nikolsky. In this false Nikolsky, there is no acantholysis, but there is a necrosis. There is a necrosis of the keratinocyte. So in which disease there is an extensive necrosis of the keratinocyte? It is a toxic epidermal necrolysis. It is a toxic epidermal necrolysis. We commonly use this short form TEN. Toxic epidermal necrolysis. Nikolsky sign पे बहुत सारे MCQ पूछता है. Okay, repeatedly they ask this MCQ. If you see the question, then they multiple times ask Nikolsky sign. So you should know this. What is this diagnostic method? This is a diascopy. कल बात की थी हमने नेवुस डिपिगमेंटोसिस और नेवुस एनीमिकस को डिफरेंशिएट. So diascopy में ना 3 important MCQ ये लोग पूछते हैं. There are 3 MCQ. The first we discussed yesterday in nevus anemicus and nevus depigmentosus. What will happen in nevus anemicus? Border will expand. It will change. Second is to differentiate peripura and the erythema. So in which disease how you develop erythema? Erythema will develop when there is an increased blood supply due to vasodilation. Suppose this patient is having, classical example I can give you is a cellulitis, right? In cellulitis, what happened? Because of the superficial skin infection, I have a vasodilation. And because of the vasodilation, what is happening? There is a vasodilation and increased blood flow, so I will have a erythematous rash. Erythematous means more redness. Whereas what is this? This is the purpura, because it is less than 1 centimeter. What is the larger form of a subcutaneous bleeding? Ecchymosis. Purpura versus ecchymosis. So, what I will do? I will press this lesion, because this in this purpura the skin is deposition of the hemosiderin or iron content of the blood. So it will not expand. It will remain the same even after pressing with the glass slab. But because this cellulitis or erythema is developed because of the vasodilation. So in the vasodilation, when I will press this region, what will happen? I will disperse this blood and I will see the normal skin color. So this response is known as a blanching response. What is this response? This response is a blanching response. So blanching is present in the erythema. We will write down these 2 important points on the diascopy. if the patient is having the erythema, it shows the blanching response. Whereas purpura will show non-blanching response. Okay, तो ये हमारा second MCQ point हुआ. Third is they ask apple jelly nodule appearance. Apple jelly nodule appearance on the diascopy. Which two disease shows apple jelly nodule appearance on the diascopy? These diseases are lupus vulgaris and a cutaneous leishmania. It is a lupus vulgaris and the cutaneous leishmania. खाली वुडलैंड में दो डिजीज की बात कर लेते हैं. You know neurofibromatosis, right? You all know neurofibromatosis, right? So what is the rash of neurofibromatosis? There are two important rashes they ask. One is the cafe outlet spot and the second is the S-leaf macule. So how to differentiate this? Which is a hyperpigmented, which is a hypopigmented? It is a cafe outlet spot, is a hyperpigmented, which we will see on a woodland, and the S-leaf is a hypopigmented. So generally what I tell the student is, remember cafe means coffee, coffee color. So cafe outlet. So remember, cafe outlet spot is seen in neurofibromatosis. The opposite is a S-leaf macule, which is seen in a tuberous sclerosis. So remember, cafe means coffee, and this rash is a hyperpigmented. So this rash is a hyperpigmented rash. Whereas S-leaf macule is a hypopigmented rash. S-leaf macule is a hypopigmented rash. In woodland, we use 365 nanometer wavelength. The light which is used in woodland is a 365 nanometer. They ask that filter is made up. Filter is made up of barium silicate and the nickel oxide. Barium silicate and nickel oxide. So for half an hour break लेते हैं. Okay. For the half an hour we will take break and we will start with the fungal skin disease. Ventilating है.